topic is the adrenergic agonists and antagonists. Now, the adrenergic agonists produce their effects by activating adrenergic receptors. Since the sympathetic nervous system acts through the same receptors, responses to adrenergic agonists and responses to stimulation of the sympathetic nervous system are very similar. So because of this similarity, adrenergic agonists are often referred to as sympathomimetics. And adrenergic agonists have a broad spectrum of indications, ranging from heart failure to asthma to preterm labor. Now, for the mechanism of adrenergic receptor activation. So for the direct mechanism, the receptor activation through direct binding is the most common mechanism. So it activates the peripheral adrenergic receptors and produce their effects by binding and mimicking the actions of the natural transmitters. So example will be your dopamine, epinephrine, isoproterenol, and your ephedrine. Now for the indirect mechanism, we have the promotion of the norepinephrine release. So by acting on terminal of sympathetic nerves to cause norepinephrine release, drugs can bring about indirect stimulation and activation of the adrenergic receptors. So example will be your amphetamine and the ephedrine. Second indirect mechanism would be the inhibition of the norepinephrine reuptake. So, by blocking the norepinephrine reuptake, drugs can cause norepinephrine to accumulate within the synaptic gap and can thereby increase receptor activation. So, agents that act by this mechanism include the cocaine and the tricyclic antidepressants. And lastly, the inhibition of MAO or the monoamine oxidase. So drugs that inhibit MAO can increase the amount of norepinephrine available for release and enhance receptor activation. So example of MAO inhibitors is your phenelzine, sertraline, and the isocarboxacid. So in this table, the adrenergic agonists are divided into two. We have your catecholamines and we also have the non-catecholamines. So we have the different types of drug and the receptors activated by each drug. So your epinephrine, we have your alpha 1, alpha 2, beta 1, and beta 2. Norepinephrine, we have your alpha 1, alpha 2, and beta 1. Isoproterenol, we have beta 1 and beta 2. Dobutamine only activates the beta 1. Dopamine can activate alpha 1, beta 1, and the dopamine receptors. For the non-catecholamines, we have here the ephedrine with alpha 1, alpha 2, beta 1, and beta 2 activated, phenylephrine with only alpha 1, and albuterol with beta 2. So as a review for the receptor subtype, so the alpha 1 is located mainly in the eye. So the response will be contraction of the radial muscle of the iris causing mydriasis or increased pupil size. In the arterioles, skin, viscera, and mucous membranes, it can have a response of constriction. In the veins, you can also have constriction. In the sex organs in males, have ejaculation. The prostatic capsule, we have contraction. And in the bladder, contraction of trigone and the sphincter. Now, on the alpha 2, they are mainly located in the presynaptic nerve terminals. So, the response will be inhibition of transmitter release. Now, for the beta 1, they are mostly located in the heart and in the kidneys. So, in the heart, it decreases rate, increase the force of contraction, and decrease the AV conduction velocity. In the kidney, they release renin. For the beta 2, they are located in the arterioles of the heart, lung, and skeletal muscle, and the response will be dilation. In the bronchi, there will be dilation. In the uterus, there will be relaxation. In the liver, glycogenolysis, and the skeletal muscle will be enhanced contraction and glycogenolysis. For the dopamine, they are located in the kidney, and its effect will be dilation of kidney vasculature. Now, for the clinical consequences of alpha-1 activation. So, they are the drugs capable of activating alpha-1 receptors include the epinephrine, norepinephrine, epinephrine, ephedrine, and the dopamine. So, the therapeutic applications of alpha-1 activation include the vasoconstriction, such as in blood vessels of the skin, viscera, and mucous membrane, and the mydriasis. So of the two, vasoconstriction is the one which alpha-1 agonists are used most often. Now for the therapeutic applications of alpha-1 activation, so first is your hemostasis. So alpha-1 stimulants are given to stop bleeding primarily in the skin and mucous membrane. So example of this is your epinephrine, which can be applied topically. Now, another application is your nasal decongestion. So example drug is your phenylephrine. So drugs can relieve congestion by causing alpha-1 mediated vasoconstriction. Next is your adjunct to local anesthesia. Another example of this is your epinephrine. So alpha-1 agonists are frequently combined with local anesthesia to delay systemic absorption. Also for the elevation of blood pressure. So because of their ability to cause vasoconstriction, alpha-1 agonists can elevate blood pressure in hypotensive patients. Also for mydriasis or dilation of the pupil. So activation of the alpha-1 receptors on the radial muscle of the iris can cause mydriasis or dilation of the pupil. So for the clinical consequences of alpha-2 activation. So alpha-2 receptors in the periphery are located presynaptically and their activation inhibits norepinephrine release. So several adrenergic agonists are capable of causing alpha-2 activation. However, their ability to activate alpha-2 receptors in the periphery has little clinical significance because there are no therapeutic applications related to activation of peripheral alpha-2 receptors. So alpha-2 receptors in the CNS are of great clinical significance. So we have two useful effects. First is the reduction of sympathetic outflow to the heart and blood vessels. Second will be the relief of severe pain. So the central alpha-2 agonists used for the effects on the heart and the blood vessels and the agents used to relieve pain are discussed in the textbook. Now, for the clinical consequences of beta-1 activation. So, there are therapeutic applications of the beta-1 activation. First is the heart failure. So, in heart failure, there is reduction in the force of myocardial contraction. So, beta-1 activation will produce positive inotropic effect. Positive inotropic effect means it increases the force of the contraction. Next would be shock. So in shock, there is profound hypotension and greatly reduced tissue perfusion. So beta-1 activation will produce increased cardiac output and can thereby improve tissue perfusion. Next will be the AV heart block. So AV heart block, there is an impulse conduction blockage. So if we activate beta 1 activation, we can overcome the AV block. Next will be cardiac arrest. So example, when we can activate beta 1 is by giving epinephrine. It can be injected directly into the heart or endotracheally. Now, for the clinical consequences of beta 2 activation. So they are limited into the lungs and the uterus. So first is for asthma. So in asthma, adrenergic agonists that are selective for beta-2 receptors such as your albuterol are preferred to less selective agents such as your isoproterenol. So this is true for patients who suffer from angina pectoris or tachycardia because drugs that can activate beta-1 receptors would aggravate these cardiac disorders. And also, beta-2 activation is used to delay preterm labor. So activation of beta-2 receptors in the uterus relaxes uterine smooth muscle. So this action can be employed to delay preterm labor. How about for the dopamine receptor activation? So, it causes dilation of the renal vasculature. So, this effect is employed in the treatment of shock. And dopamine is the only drug available that can activate dopamine receptors. So, it should be noted that when dopamine is given to treat shock, the drug also enhances cardiac performance because it also activates beta-1 receptors in the heart. Now, for the multiple receptor activation, we have here the treatment of the anaphylactic shock. So, anaphylactic shock is a manifestation of severe allergy characterized by hypotension, bronchoconstriction, and edema of the glottis. So, the treatment is the epinephrine, injected IM or IV. So, it is a treatment of choice which would activate the three types of the adrenergic receptors. So for the alpha 1, there will be mediated vasoconstriction because epinephrine increases the blood pressure. Activating the beta 1 receptors can increase the cardiac output, helping to elevate the blood pressure. And activating the receptors in the beta 2 can counteract the bronchoconstriction in the anaphylactic shock. And now for the prototype drugs, for the adrenergic agonists, we have here the epinephrine. And for the beta-selective adrenergic agonists, our prototype is the isoproterenol. Now, epinephrine, the receptor specificity is your alpha 1, alpha 2, and can also activate the beta 1 and the beta 2. So the chemical classification of epinephrine is the catecholamine. So it is among the first adrenergic agonists employed clinically and can be considered prototype of the sympathomimetic drugs. Now, epinephrine can cause therapeutic uses if it is activated on the alpha 1, beta 1, and beta 2 receptors. So, for the alpha 1, it can delay absorption of local anesthetics, control superficial bleeding, and elevate blood pressure. For the beta 1 receptors, it can overcome AV heart block, restore cardiac function. And for the beta 2 receptors, it can cause bronchodilation. Now for the pharmacokinetics of epinephrine. So it is absorbed by topical or by injection. So absorption is more rapid following intramuscular injection and is immediate with intravascular administration. So it has a short half-life because of two processes. So we have the enzymatic inactivation with MAO and COMT and uptake into adrenergic nerves. And now, these are the adverse effects of the epinephrine. So first is your hypertensive crisis. So vasoconstriction secondary to excessive alpha-1 activation can produce a dramatic increase in the blood pressure, causing hypertensive crisis. Epinephrine can also cause dysrhythmias. So excessive activation of beta-1 receptors in the heart can produce dysrhythmias. Also, it can also cause angina pectoris. So, by activating beta-1 receptors, epinephrine can increase cardiac work and oxygen demand. So, if the increase in oxygen demand is significant, an anginal attack or angina pectoris may ensue. Next will be necrosis following extravasation. So, if an IV line containing epinephrine becomes extravasated, the ensuing localized vasoconstriction may result in necrosis. And lastly, epinephrine can cause hyperglycemia, especially in patients with diabetes, because um, epinephrine can cause breakdown of glycogen secondary to activation of beta-2 receptors in the liver. And now for the preparation, dosage, and administration of your epinephrine. So, epinephrine is given either through IV, IM, sub-Q, intracardiac, intraspinal, inhalation, or topical. So, they are available in 0.1 mg per ml and 1 mg per ml ampule. So, if we give epinephrine, we observe for signs of the excessive cardiovascular activation, such as the tachydysrhythmias, hypertension, and for possible extravasation of the IV line. Now for the norepinephrine. So they are similar to epinephrine, but norepinephrine has receptor specificity to alpha-1, alpha-2, and beta-1. Chemical classification is the catecholamine. It can elicit all of the responses similar to epinephrine except that are beta-2 mediated, such that norepinephrine does not promote hyperglycemia. So responses can be modified by MAO inhibitors, the tricyclic antidepressants, general anesthetics, and the adrenergic blocking agents. So despite its similarity to epinephrine, norepinephrine has limited clinical applications. So the only recognized indications are hypotensive states and cardiac arrest. So it is available in solution 1 mg per ml for administration by IV infusion only. So we monitor cardiovascular status continuously and we assess the patient's status frequently and to avoid extravasation. Next would be the dopamine. So dopamine receptor specificity is your dopamine, the beta-1, and high doses, the alpha-1. So chemical classification is it is an catecholamine. So, in low therapeutic doses, dopamine receptors are activated. So, at moderate receptors, aside from dopamine receptors, it also activates the beta-1 receptors. And at a very high doses, aside from activating dopamine and the beta-1, it also activates the alpha-1 receptors. Now, for the therapeutic uses of dopamine, the major indication is shock, and it can be also used in heart failure. Now, the adverse effects of dopamine are tachycardia, dysrhythmias, and anginal pain. It is contraindicated for patients with tachydysrhythmias or ventricular fibrillation. So extravasation may result in necrosis from localized vasoconstriction. Now, for the preparation and dosage and administration of the dopamine. So, it is available in 0.8 to 160 mg per ml, and the dosage is usually 2 to 5 microgram per kilogram per minute and given via IV and in continuous infusion. And cardiovascular status must be closely monitored while giving dopamine infusion. Next would be dobutamine. So for the receptor specificity is only for beta 1. Chemical classification, it is for catecholamine. So for the actions and uses, at therapeutic doses, dobutamine causes selective activation of beta 1 adrenergic receptors, and the only indication for the drug is heart failure. Now, for the adverse effects of dobutamine, the major adverse effect is your tachycardia. Blood pressure and the ECG or electrocardiogram should be monitored closely while giving your dobutamine. Now for the preparation, dosage, and administration of your dobutamine. So dobutamine is available in concentrated solution in 12.5 mg per ml in 20 and 40 ml vial. It is given by continuous IV infusion with a usual rate of 2.5 to 10 microgram per kilogram per minute. Next will be the albuterol. So albuterol receptor specificity is your beta 2. Chemical classification, it is a non-catecholamine. Now, the therapeutic uses of the albuterol. So, albuterol is used in asthma. It can reduce the airway resistance in asthma by causing beta-2 mediated bronchodilation. Because albuterol is relatively selective for beta-2 receptors, it produces less activation of the cardiac beta-1 receptors than does isoproterenol. The adverse effects of the albuterol consist of tremor, which is most common, and tachycardia by activating beta-1 receptors in the heart. And now, let's go to adrenergic antagonists. So, adrenergic antagonists cause direct blockade of adrenergic receptors, with one exception. All of the adrenergic antagonists produce reversible or competitive block. Now, for the therapeutic responses to alpha blockade are the following. First is the essential hypertension. So, blocking the alpha-1 receptor with alpha or adrenergic blocking agents can decrease the blood pressure in patients with essential hypertension. Also, for the reversal of toxicity from alpha-1 agonists, especially with epinephrine. So, if there is toxicity in giving epinephrine, we give alpha-1 blocker. Also, it is also used in BPH. So, benign prostatic hyperplasia, there is an increase in the proliferation of cells in the prostate gland. So if we give adrenergic blocking agents, it can decrease the BPH. And also, it is also used in pheochromocytoma. So as a review, pheochromocytoma is a catecholamine secreting tumor. So since it is a catecholamine secreting tumor, there is an increase in the alpha-1 receptor functions, wherein there will be increase in the blood pressure. So we give alpha blockade drugs to counteract the effect of the alpha-1 receptors. And lastly, alpha blockade is used in Raynaud's syndrome. So Raynaud's syndrome or Raynaud's disease is a peripheral vascular disorder characterized by vasospasm in the toes and fingers. So alpha blockers or adrenergic antagonists can suppress symptoms by preventing alpha-mediated vasoconstriction. So here is the adverse responses to alpha blockade. So first is the orthostatic hypotension, wherein it is the most serious adverse response to alpha adrenergic blockade. Next would be the reflex tachycardia. So alpha adrenergic antagonists can increase heart rate by triggering the baroreceptor reflex. Next will be nasal congestion. So alpha blockade can dilate the blood vessels of the nasal mucosa, producing nasal congestion. Next will be inhibition of ejaculation. Because activation of alpha-1 receptors is required for ejaculation, blockade of these receptors can cause sexual dysfunction. And lastly, the adverse response to alpha blockade is your sodium retention and increase in blood pressure. So, by reducing blood pressure, alpha blockade can promote renal retention of sodium and water. So we have here the prototype drug for the adrenergic antagonist. So we have here the selective alpha-1, meaning it only functions on the alpha-1 adrenergic antagonist. So we have here the prazosin. So this is an alpha blocker. We also have a non-selective beta adrenergic antagonist. So it also acts in beta 1 and beta 2. We have here the propranolol. And we have a selective, so it only acts on the beta 1 receptors. So example of a beta blocker, which is a selective adrenergic antagonist, is your metoprolol. So first up for the adrenergic antagonist is your prazosin. So it is used as a competitive antagonist for selective blockade of alpha-1 adrenergic receptors. So the result is dilation of arterioles and veins and relaxation of smooth muscle in the bladder neck, the trigone and the sphincter, and prostatic capsule. So it is approved only for hypertension but can also benefit men with BPH or your benign prostatic hyperplasia. So the pharmacokinetics of the prazosin, so it is administered orally. So antihypertensive effects peak in 1 to 3 hours and persist for 10 hours. So the drug undergoes extensive hepatic metabolism followed by excretion in the bile. So only 10% is eliminated in the urine and the half-life is 2 to 3 hours. And now for the adverse effects of prazosin. So we have three: orthostatic hypotension, reflex tachycardia, and nasal congestion. Of the three, orthostatic hypotension is the most serious. So here are some of the drugs used as an alpha blocker. So we have non-selective agents, your phenoxybenzamine, available in tablet, and it is given twice daily. We have also your pentolamine. And also we have the alpha-1 selective agents. So we have the alphozozine, doxazozine, doxazozine ER, prazosin, which is the prototype of the alpha blocker. We have silodosin, tamsulosin, and your terazosin. Now, for the beta-adrenergic antagonists, these are the following therapeutic and adverse responses to beta blockade. First, we have angina pectoris, we have hypertension, We have cardiac dysrhythmias, myocardial infarction, reduction of perioperative mortality. It is also used in heart failure, in hyperthyroidism, in migraine prophylaxis, also in stage fright, and can also be used in patients with pheochromocytoma. And so, these are the non-selective beta blockers, first generations. So we have nadolol, pindolol, propranolol, sotalol, and timolol. Of the first generation, the prototype here is propranolol, which is a beta blocker non-selective, meaning it can act in both beta 1 and beta 2. We have also here the second generation. We have the cardioselective beta blockers. We have acetylbutolol, atenolol, betaxolol, bisoprolol, and your esmolol and your metoprolol. So the prototype here for the selective beta blocker is your metoprolol. And we also have third generation beta blocker with vasodilating actions. We have here the carvedilol, labetalol, and your nevebolol. So, for the propranolol, it is the prototype of the first generation beta blockers and it produces non-selective beta blockade. So it blocks the beta 1 and beta 2 adrenergic receptors. So if you block beta 1 receptors, the net effect is a reduction in cardiac output and it suppresses the secretion of renin. And blocking the beta 2 receptors can cause bronchoconstriction, vasoconstriction, and a reduced glycogenolysis. Now, for the pharmacokinetics of the propranolol, it is highly lipid soluble. It is well absorbed following oral administration, and less than 30% of each dose reaches the systemic circulation. It is widely distributed to all tissues and organs, including the CNS, and it undergoes hepatic metabolism followed by excretion in the urine. And so for the therapeutic uses of propranolol, so practically all of the applications of propranolol are based on the blockade of beta 1 receptors in the heart, and the most important indications are the hypertension, angina pectoris, cardiac dysrhythmias, and myocardial infarction. So for the adverse effects of propranolol are the following. So the most serious adverse effects result from blockade of beta 1 receptors in the heart and blockade of beta 2 receptors in the lungs. So first is your bradycardia. So beta 1 blockade in the heart can cause bradycardia and heart rate should be assessed before each dose is given. Next will be AV heart block. So by slowing conduction of the impulses through the AV node, propranolol can cause AV heart block. Also, it might cause heart failure. So in patients with heart disease, suppression of myocardial contractility by propranolol can result in heart failure. Next will be rebound cardiac excitation. So, abrupt withdrawal of propranolol can cause rebound excitation of the heart, resulting in tachycardia and ventricular dysrhythmias. Propranolol can also cause bronchoconstriction. So, blockade of beta 2 receptors in the lungs can cause bronchoconstriction. Next will be inhibition of glycogenolysis. So blockade of beta 2 receptors in skeletal muscle and the liver can inhibit glycogenolysis. It can also have a CNS effects. So because of its lipid solubility, propranolol can readily cross the blood-brain barrier and has access to the CNS. It can cause depression, nightmares, and hallucinations. And propranolol has also effects in neonates. So it crosses the placental barrier. So using propranolol and other beta blockers during pregnancy may put the neonate at risk of bradycardia and respiratory depression. And for the drug interactions, if propranolol is given with calcium channel blockers such as your verapamil and deltazim, it can cause reduction of heart rate, suppression of AV conduction, and suppression of myocardial contractility. And if it is given with insulin, propranolol can impede the early recognition of insulin-induced hypoglycemia, and it can also block glycogenolysis. So propranolol is available in tablets or an oral solution. So it could be 10 to 80 milligram or in oral solution or for IV administration. For the dosage, for hypertension, the initial dose is 40 milligram twice a day or 80 milligram once a day. For angina pectoris, it is usually 80 milligram once a day. And IV administration of propranolol is not routinely done except in emergency situations. Now, for the metoprolol. So metoprolol is the prototype of the second generation beta blockers. So it produces selective blockade of beta 1 receptors in the heart. So it is not likely to cause bronchoconstriction or hypoglycemia. So for the pharmacologic effects of metoprolol, it reduces the heart rate, the force of contraction, and the conduction velocity through the AV node. So it reduces secretion of renin by the kidney. And it does not block the bronchial beta 2 receptors at usual doses. The pharmacokinetics, it is very lipid soluble and well absorbed following oral administration. So like propranolol, metoprolol undergoes extensive metabolism on its first pass through the liver. So as a result, only 40% of an oral dose reaches the systemic circulation. And elimination is by hepatic metabolism and renal excretion. Therapeutic uses of the metoprolol, the primary indication is hypertension. The drug is also approved for angina pectoris, heart failure, and myocardial infarction. IV administration of metoprolol is reserved for treatment of myocardial infarction. So the adverse effects of the metoprolol are the following. So the major adverse effects involves the heart. Like propranolol, it can cause bradycardia, reduced cardiac output, AV heart block, and can cause rebound cardiac hesitation following abrupt withdrawal. So even though metoprolol is approved for treating heart failure, it can cause heart failure if used incautiously. So in contrast to propranolol, metoprolol causes minimal bronchoconstriction and does not interfere with beta-2 mediated glycogenolysis. Now, metoprolol is available in IR tablets as 20, 50, and 100 milligram tablet. IR means immediate release tablets. ER tablets, or also known as extended release tablets, are available as 25, 50, 100, and 200 milligram. They can also be available as a solution in 1 milligram per ml for IV. So initial dosing is 50 milligram twice daily or 100 milligram once daily. And as stated earlier, intravenous administration is reserved for myocardial infarction. So as a review again, these are the first generation non-selective beta blockers. So we have nadolol, pindolol, propranolol, IR, and propranolol ER, and sotalol, and timolol. The second generation cardioselective beta blockers are your acebutolol, atenolol, betaxolol, bisoprolol. And we have here the esmolol, metoprolol, and IR and metoprolol ER. Now for the third generation beta blockers, so they have vasodilating actions. So we have the carvedilol, IR and carvedilol ER tablets and capsules. And we have here labetalol and nevebolol. And thank you for watching.